Canada is known throughout the world for its universal healthcare system. However, the establishment of this system, as we know, was not an easy one. It was fought for by people across the country through strikes, protests, and petitions, and many of you will remember those days and be reminiscing about that tonight. We continue to have to defend Medicare despite national polls that show that between 94 and 97% of Canadians support the Medicare system. Saskatchewan led the way for Canada's healthcare system by taking the first steps in the early 1940s through to the establishment of the Medical Care Insurance Act in 1962. Saskatchewan demonstrated to the rest of Canada and the world that a national, universal, public healthcare system was indeed possible. We have to sort of focus on that provincial election of 1960 that gave the Tommy Douglas CCF government the mandate to introduce the Medical Care Insurance Plan, the first of its kind in North America. While the bill passed in 1961, its implementation was delayed in an effort to reach a compromise with physicians. And when Tommy Douglas left in 1961, Woodrow Lloyd became the leader of the CCF, as many people will remember, and was tasked with the implementation of that bill. It wouldn't be an easy task. Many Saskatchewan doctors opposed the plan and threatened to strike if the bill was implemented. Citizens and communities were also often divided, some supporting the plan, some not. In the months leading up to the implementation, groups of citizens began to meet throughout the province. And with the support of a few doctors, they began to establish cooperative healthcare clinics in more than 30 Saskatchewan communities to ensure residents had medical services in the event of a doctor's strike. The Saskatoon Community Clinic was one of those clinics. On July 1st, 1962, 50 years and 2 days ago now, the Medical Care Insurance Plan came into law, and while the doctors embarked on a 23-day strike, community clinics swung into action, helping to ensure Medicare not only survived, but thrived in Saskatchewan. Tonight, we are here to celebrate this historic achievement. Medicare had a difficult beginning in this province, but managed to survive due to the tenacity and courage of so many citizens, including the founders of the Saskatoon Community Clinic. Medicare was eventually adopted throughout Canada and has become a defining feature of what makes us Canadians. We're also here tonight to look forward. Medicare and community clinics have served our citizens well over the last 50 years, and the spirit and hopes of our pioneers continue at our West Side and downtown clinics. The Cooperative Saskatoon Community Clinic is a leader in a primary health care model that focuses on prevention and promotion of good health as well as treatment. So I have the honor now of introducing our team of dramatic readers, led by Don Kerr, Poet Laureate of
This province has been sick. It has had a major operation. It is just convalescent. I prescribe for an absolute rest. This is a doctor's order, absolute rest. This prescription was given to the people of Saskatchewan by Lord Taylor at the end of the 3-day doctor's strike. Those who supported them were called the KOD, Keep Our Doctors. And they kept speaking their piece, so I thought we might call them the cod piece.
On May 9th, 1962, Woodrow Lloyd spelled out what his government regarded as the fundamental issue. The issue is whether the people of Saskatchewan shall be governed by a democratically elected legislature, responsible to the people, or by a small, highly organized group. The people of Saskatchewan have been served notice by this organization. The notice is that until we repeal the Medical Care Insurance Act, or unless the group is permitted to ignore this act of a duly constituted government, the people of the province will be punished by curtailment of medical services. It is to be hoped that our individual doctors will think carefully before they allow their health-giving skills to be used in this way, as instruments of compulsion and coercion.
On June 29th, Regina's Medical Society announced a 5-pronged policy, effective July 1st. 1. All doctors' offices will be closed to patients. 2. No doctors will be available for home visits except in the direst emergencies. 3, no telephone advice will be available from doctors. 4, there will be no prescription services. 5, medical legal documents will not be procurable. The patient will have no choice of doctor, and it is likely the emergency services will become more and more limited as the days progress.
On Friday, July the 6th in Saskatoon, Father Athol Murray of Wilcox gave a speech. The wave of hatred was sweeping Saskatchewan. There has been death, there would be violence, and there could be bloodshed. Tearing off his coat and clerical collar, Father Murray shouted, "There are 3 Reds here. I can't see them. I can smell them." You communists may think we're naive and hollow-chested. Apparently one of those communists was Romano. You communists may think we're naive and hollow-chested, but we gave 100,000 boys fighting for the freedom you're fighting against. You Reds, I want you to know, we're as proud as hell to be Canadians. Tell those bloody commies to go to hell when it comes to Canada. I loathe the welfare state and I love the free swinging freedom. I'm 70 and I'll never ask for that damn old age pension. To hell with it. I want to be free. We're living in a tragic time. The Ku Klux Klan has come to Canada. 17 doctors left Swift Current. We're proud of them. These doctors are great guys. The provincial government told us they were bluffing. They weren't. I wouldn't be surprised if someone put a bullet in me. I'm as likely to get it as Woodrow Lloyd. We learned, but I don't know if it's true, that the bishop told him it's time to leave. He said, "Well, I don't want to leave." He said, "This isn't a request."
I was expecting my first baby in August. Before I left to visit my family, I asked my doctor if he would be seeing his patients in July. He told me he would be there and that I could get an appointment with him. When I called on my return, all that I heard was a recording saying that if I was in need of medical care, I was to go to one of the emergency health centers. So I went to a doctor instead who was not on strike. After the strike was over, patients were supposed to return to their doctors. But I just couldn't do this. He had let me down, so I would never be able to trust his word as a doctor again.
Ellen Blakeney says there were 2 papers in favor of Medicare in Saskatchewan. The Waukau Recorder and the Prairie Messenger, which was a Catholic weekly, so you can see part of the world. He says the Regina Leader-Post and the Saskatoon Star-Phoenix abandoned all semblance of reporting news impartially and campaigned in editorials and news columns against the Medicare plan. Blakeney lists many of the newspapers that were there from Canada, the United States, and Great Britain because the issue became an international issue. And some of those papers wrote articles saying how bad those daily papers had been, and their reply was, "Well, we're right here. We know the province best." And John Barry gave me that was from Ellen Blakeney's book, An Honourable Calling, Political Memoirs. John Barry gave me a list of outside press, and I'll just read a couple of them. Washington Daily News, Saskatchewan doctors are sick, sick, sick. Their strike has shocked people. London Daily Mail, when doctors strike and neglect patients, the voice of humanity protests. That this should happen in Britain is inconceivable. We regard Saskatchewan with astonishment and sadness.
Mr. Donald D. Tansley, State Medical Service, People's Health and Welfare Building, Regina, Saskatchewan. Sir, the above-mentioned doctors do not wish to have you ever write to them, communicate with them, speak to them in any manner, shape, or form. I've told you this before, but apparently you are such a moron or idiot that you pay no attention. Unless you do not speak or read English, in which case I forgive you. This socialist garbage in printed form is an insult to any normal human being. Yours in bitter hatred.
Mr. Lloyd then concluded, "My appeal is to what has been termed the ancient wisdom of your profession, We seek not to change the ends of medicine. We do seek to find ways and means to adapt the financing of Medicare to 20th century society and the legitimate expectations of that society. In this, the ancient mission need not be lost. Its achievement can be advanced. I invite you to join in a bold attempt to consolidate past gains and to move forward new horizons in the field of medical care.
Dr. Ted Tolchinsky was one of the few Canadian physicians who was regarded as a strikebreaker. He was sent by the Commission to the town of Priesteville. One evening, a middle-aged lady came into the hospital announcing that she had come from a local KOD rally. She wanted to know if a doctor would come out to her farm to see her old grandmother, who apparently had just died. I volunteered to go and followed in my car. She got into her car with 6 bulky farmers, and I followed them far out into the country, fearing this might turn out to be a rough ride. It turned out, however, to be a true bill. After I certified the deceased, I was faced with excruciating politeness by those who hated my presence. In the second week of the strike, a call came that there had been a bad car accident. A car soon rolled up to the hospital with 2 heavily bleeding men with multiple cuts about the head and neck. One man in his 60s was bleeding profusely. I stopped the bleeding points and restored his blood pressure with intravenous infusions. The other man had a possible head injury, but this turned out to be a false alarm. The nearest emergency center was at Yorkton, 60 miles away. I don't believe the man in shock would have lived to reach that center. There was justification for my being in Priesteville.
Lord Taylor, member of the House of Lords and physician, was brought from England to negotiate between the doctors and the government. The government has made concessions. Dr. Dalgleish has made a speech to the CCF convention before I met him, and he has made concessions. So we were already on the way. It was like a sort of battle operations room we got in this hotel. It was a most wonderful and amusing situation, and we were all drafting away like Billy-O. Then I took the thing over to the doctors. Then I took the objections back to the government. I was getting more and more tired. I packed my grip. I told the doctors, I'm fed up with this. I'm utterly fed up to the teeth. I cannot take it anymore. Either you agree or I'm off. And they begged me to stay. We had a frightful struggle over certain phrases and certain words. I lost my temper. I swore and raved. I got up that next morning and I was in my bath. Dr. Clarkson came in and said, it's all right. They're going to sign it. It was a wonderful moment. Then the signing was done beautifully. It was done in the Prime Minister's suite at the Bessborough.
Canadians do not have free health care. Canada does have a medical insurance system for which every Canadian pays premiums. Perhaps the most important feature of Medicare is its universality. At present, Canadians could go anywhere in Canada or outside the country safe in the knowledge that they can obtain medical treatment if needed. User fees, a popular suggestion these days, would sound the death knell of Medicare. Far from feeling guilty about passing on a healthcare system for which Canada is the envy of every other country in the world, I hope the younger generation is smart enough to appreciate the marvelous system they will inherit. There is not one thing wrong with Medicare that cannot be corrected. That is from W.H. Mowat, Wolfville, Nova Scotia.
After 7 rather rough days crossing the Atlantic in the Cunarda, and nearly 3 days on the train, that the 2 families, John Garson and myself and our families, arrived just after 8 o'clock in the morning on June the 13th to the downtown CN station to be greeted by a crowd of almost 200 people. Over the next 3 days we went into a whirlwind of activity. We had both bought houses by 3 o'clock the day we arrived, with mortgages arranged by the Saskatoon Credit Union. Next day we had both bought cars. And during those first 3 days, we had a whirlwind of parties night after night after night. And I said in the last one, I thought if the work was going to be as bad as the parties, we wouldn't last out very long. We soon found out that we were caught in what I call the slipstream of the doctor's strike. It's very hard now, and even then, to imagine what it must have been like to set up a patient-owned medical cooperative against the opposition of the powerful and heavily supported medical profession. But a sense of their atmosphere can be caught in the headlines of the Public Voice, a weekly journal published out of the office of the Saskatchewan Federal Labour by the Saskatchewan Citizens for Medicare, 4 of which copies you can see on the display, and 1 of which is displayed behind me. This was published every week during the strike and was mailed to every household in Saskatchewan. The headlines read, July the 7th, doctors refuse compromise. Leader post misleads public. Nothing's changed there. July the 14th, rapid growth for the co-op clinics. Quote, and a quote from the London Times. Detached observers may think it regrettable that the doctors' intransigence has reached the length of going on strike to allow politics, and it's only politics, to disturb the doctor-patient relationship not in accordance with the Hippocratic Oath. On October the 1st, you can see the headline appeared in the last edition of the People's Voice. So it was in this tense, exciting, warlike atmosphere that the clinic opened on July the 3rd, on the 3rd floor of the Avenue building, in a bare room with 2 black telephones, 2 folding tables brought across from the road from the Union Centre, covered with mattresses which someone had brought home from home, and 2 valiant doctors, Doctors Joan Whitney Moore and Dr. Margaret Hood, together with Nurse Grace Deverell. Some nights the doctors had to be accompanied home because of threats of violence made against them. Premier Woodrow Lloyd had to have a Mountie bodyguard during that period of time. Sam Walsh, who was a professor at the university, lost his job because he came to work for the clinic during the strike. Equipment had to be found and paid for, donations came in fast enough, people took loans, some second mortgaged their homes, and later we sold debentures. We got a whiff of this hostility when we registered at the college in 1963. The registrar told us that we would be practicing in a clinic that they had critical ethical anxieties about. They were still anxious in 1979 when they warned Dr. Eisenhower when they were registering her that she would be working in a commie clinic. The community clinics were unpopular because they threatened the autonomy of the medical profession. And as we worked on salaries, the profession was terrified that the government was using the clinics as a backdoor way of establishing a salaried medical service. In fact, for the first 9 months, the clinic did receive payment of doctors' incomes from MCIC, the Medical Care Insurance Commission. But in March 1963, I think the government lost their courage. MCIC cancelled that arrangement and made it retroactive, so that we had to go back over the records and translate all our patient charts into fee-for-item to service claims. A horrific task. When John and I arrived, we were still arguing with the government over this issue and threatened to picket the Premier Lloyd when he opened St Paul's Hospital. He came up to the clinic that morning. I remember it was a beautiful sunny morning. We were on the second floor of the community. We moved down to the second floor of the community by that time, and he talked us out of it. So when we're accused of being the patsies of the CCF, it's not absolutely true. So it's very difficult for those who have attacked the clinic to accuse us of being the creatures of the government. In fact, salaried medical care was rejected by Tommy Douglas as early as 1945, when he first looked at developing medical care insurance. And as far as I can determine, the government had no intention of creating a medical service. They were creating a medical insurance service, and that's what they still have. It's a medical care insurance is what we have. It's not a health system. And it was a pity that he did that, as he's left the running of medical services to the doctors and the health administrators, with no method of evaluation. In addition, the Saskatoon clinic was a group practice with a mixture of general practitioners and specialists, and we opened in the morning, which was not the practice in Saskatoon at the time. Into this heated and still tumultuous atmosphere, John Garson, Mel Langer and I started working on July the 3rd, 1963. We were delighted that while the battle raged outside in the Avenue building, we were working in almost ideal conditions. But on the day we started work, Doctors Wolf, Mahud, Tolchinsky, Golden, Smith, and many of the staff were down at the courthouse listening to the opening of Mr. Justice Wood's commission on why community doctors could not get hospital privileges. John and I had already been rejected by St. Paul's, and we wrote to all the doctors on the staff there to see if they were supporters. They had to sponsor us. You had to be sponsored by a doctor to get on the staff. And that applied to many hospitals in Saskatchewan. It fortunately didn't apply to City Hospital. When Dr. Medley Hayes, Chief of Staff of City Hospital, gradually processed our applications after assuring us that the hospital did not put patients on the roof like they did in the National Health Service. We tried to explain to him that we'd never experienced that, but he was not convinced. Relations with the rest of the medical profession were awkward. The doctors that had privileges, which we eventually got in September, we applied for them in June, we got them in September. They sent our application to him by surface mail, by sea, to make it as long as possible. Relations with the rest of the doctors that had privileges were closely watched in the hope that we would make mistakes and be hauled before disciplinary committees. In fact, one of the doctors at the clinic had lost his privileges before John and I had arrived, when he'd been let down by a university specialist who came over to help him, who refrained from supporting him even though he was able to do so. Many of the nursing staff were unsympathetic and some were openly hostile, and we never were sure if our instructions were being carried out properly. The first patient I admitted to hospital was starved for 2 days because I had not completed the order sheet completely. The doctors put Mel Langer, our surgeon, in Coventry by walking out of the coffee room in the operating room suite when he came in. So after that, when he'd made his rounds, Mel would sit and read the Globe and Mail while the other doctors invaded the nursing's coffee room until the nurses finally threw them out after about 3 months. In addition, the College of Physicians and Surgeons were always watching us. In 1963, we were called before a disciplinary committee for unethical conduct because the association had published a booklet on how to use the clinic for our patients, and the college accused us of advertising. Our lawyer took an injunction against the college, to which they have never replied, which was really their last legal shot after that. The college insisted that in the Saskatoon Agreement defined the relation between the association and the doctors to be that of landlord and tenant. That meant that the physicians billed the commission fee for service and turned all their income over to the association, who used it to pay all the bills, including wages and salaries. It wasn't until 1962 that the clinic and all other clinics went on a global budget and the landlord-tenant nonsense was stopped. In those early days, many weekends were taken up planning and discussions between staff and patients. It was out of one of these discussions that we came to found our drug formula. For some reason, the cost of pharmaceuticals had not been provided for in the Saskatchewan plan, and neither was it in the federal plan, even after Just Emmett Hall's report, which together with the minority report of Walter Smitty to the Thompson Committee, both recommended that pharmaceuticals should be included. It's somehow always been that surgery is exciting, magical, and somehow that's what medicine really is. In fact, it's a very small part of medicine. Most medicine is acute, minor illness, and chronic care. But nevertheless, we still don't have a proper drug formula. After studying the prescribing habits of doctors for 6 months, we were able to construct a formulary of about 200 items that covered 90% of all the prescriptions of the 8 doctors, family doctors prescribing. We were thus able to have competitive bids from the drug companies so that we would only use one brand. This saved the patients about 25%. And our experience had a significant effect on the introduction of the Saskatchewan prescription drug plan that was by far and away the most effective drug plan in the country. until the federal Liberal government caved in to the pressure from the pharmaceutical industry and established the Patent Medicines Prices Review Board that has allowed the price of drugs to rise faster than any other aspect of medical care. As an interesting side note, the Minister of Health who enacted that and introduced that act became the President of the Pharmaceutical Manufacturers of Canada the day after she resigned. We believed at the clinic that by paying proper attention to the social factors, what we now call determinants of health, that we would be able to reduce the cost of medical care by curing or alleviating the underlying cause of disease. So in 1964 we appointed our first social worker, Genevieve Teed, paid for by a federal research grant, who were also Genevieve was also one of the first board members of the clinic. And so the counselling department was formed. Through its contribution and that and other health workers, we would be able to reduce the overall cost of patient care, particularly by not having the incentive of being paid by piecework, by reducing hospital stays. We also believed that because the surgeon would be paid on salary, there would be less surgery, and so it turned out. And all the early reviews and assessments showed that the overall cost of care by community clinic patients at Saskatoon was less than what's going on in the rest of the profession. If we were not creatures of the government, we did at least play a significant part in getting rid of one of them. As members of the Citizens for Defence of Care, we mounted a public campaign opposing the introduction of deterrent fees by the Thatcher government in 1968. We held public meetings, the best of which was held upstairs in the Adam Ballroom, and where we induced Pierre Byrne to come and be our principal speaker. And it happened like this. I was really still new to Saskatchewan, but I knew about What's My Line. I knew Pierre Byrne was a person of importance. I phoned him up a Saturday morning. He was on a cruise in the Caribbean. And I said, Mr. Byrne, you don't know me. I'm Dr. Berry from the Community Clinic of Saskatoon. And I want to tell you that the Thatcher government has imposed deterrent fees on all office services and on hospitals. Say, the bastard, I quit. I said, would you come and talk to us? We're having a meeting in February on such that date. He said immediately, here's my secretary's telephone number, phone her, tell her I'm coming, and she'll make all the arrangements. And so he came. And we had a huge meeting. It went right across the concourse to the other end of the building. We eventually got 30,000 petitions, which we delivered to Mr. Thatcher, but it didn't make any difference. However, they were not elected at the next election. It was a significant factor in the defeat of the Liberal government. We had steadily made progress, and by 1970 we were in our new building on the 2nd Avenue, which we carefully designed through repeated consultation with staff. Even then we didn't please everyone and we had to do salaries over again. But by that time there were 8 family physicians, 6 specialists, 2 consulting pathologists and 65 other staff. There were 51,000 office visits and we performed 67,000 services, and there were over 200 visits a day to the clinic. We did house calls, and for several years we employed a nurse to take over after-hours telephone calls. This reduced the number of calls necessitating a doctor's visit, but more importantly, reduced the workload on the emergency departments. We should remember that in those days there were no emergency department physicians. The device was stopped. We were no longer able to get funding. One of the incredible, diabolical, stupid bureaucratic mistakes, they took away the money, and of course the costs went up because people went to emergency departments. Our nurses were able to persuade most of the patients to find out how to deal with the emergency, because most emergencies at night are high fevers in kids, little aches and pains, and about a third of them require a doctor. It's an interesting example of what Roy Romer always takes when he talks about the principle of the future of Medicare. You should always take in the total cost of any service when you're introducing a new service. In his new book, The Healthy Society, Dr. Ryan Marley, who I see is here somewhere, uses the case histories to demonstrate the effects of the determinants of health. His examples are mostly drawn from his experience at the Westside Clinic. In that location, the determinants of health are visible to the naked eye. Dilapidated housing, the couch hoppers crossing 22nd Street carrying their worldly goods in a black garbage bag, and no source of good food. However, that will soon be corrected in Riversdale's Castle Hill by the Good Food Junction grocery store that will open on September the 3rd. Give them a round of applause. I feel we've not been able to define so accurately the effects of the determinants of health in our experience on the West Side, where we treat largely the middle class. What I call the missing class, or the forgotten class, a class that's situations in the world is now declining. The effect of work back to life imbalance, the effects of uninteresting work, the lack of time for recreation, and the restriction of human connection to only family rather than community, and the pressure of the increasing income gap. We must have pages of evidence of this nature locked away in the patient's files in the counselling department. And we should be able to demonstrate the before and after effect of social counselling intervention. And from this, the Political and Social Action Committee should be able to call attention to the wider public to these issues, as they have done about housing and about pedestrian safety. We should really be a laboratory of best practice and research, and now that the tide is turning and the government, including this one, is promoting primary care, we should now be working closely with the university, as we do at the West Side, and should pursue a research capacity. We've also been sluggish in the sluggish rearrangement of professional roles. We do have at last 2 nurse practitioners, but if you read Dr. Wolfram Badgley's book, The Family Doctor, which is over on the table there, he would say that by this time, 1 family doctor, 2 nurse practitioners, 2 social work assistants, and 1 social worker for every 3,000 office visits. Perhaps if we only hire graduates from Switch in the future, we may achieve this goal. West Side's practice has come closer to that model, but as yet we haven't mobilised that community to be a force for change. In summation, we've done fairly well in a hostile world under the effect of greed capitalism that is destroying cooperation and the still entrenched attitudes of the medical profession. The commercial forces and others that opposed Medicare in 1962 are still at work, as shown by the continual charge that Medicare is unsustainable and that we should let the market have a greater and the suggestion that some private medical care would be nice and would hurry things up, forgetting the resources used in the private care reduces resources in the public system and makes the wait time longer for less affluent citizens. We must not let this happen, and Stephen Lewis, when he talks to you later on in the evening, will probably suggest some things we can do to prevent it from happening. But in the meantime, we must celebrate the 50th anniversary by doing better in the future, by being stalwarts for the preservation of universal, comprehensive, accessible, portable, and publicly administered medical care insurance plan, as well as a public health program we have to design that Tommy Douglas called the 2nd stage of Medicare. That will tackle the epidemic of obesity, diabetes, AIDS, and the decline in the nation's health caused by the effects of those determinants of health and the failure of citizens to be responsible for their own health. Thank you.
Different from the average 50-year-old Canadian. It's a bit fat, it's a bit misshapen, not too agile, addicted to consumption, too busy and often tired. So while it does some wonderful things, this baby needs to be whipped into shape a little bit. And so that 50-year-old gets to be 60, 70, 80, and 90, I offer you a few prescriptions about how to accomplish just that. The first and central one is that we have to recognize that times and needs change, and they always will change, and so must the system. It is very important to distinguish the fidelity to the wonderful values of Medicare from how those values are translated into structures, programs, funding, payment, etc. There is nothing sacred about how the system is organized. The only thing sacred is the fundamental value that this is a public program, publicly financed, and where ability to pay is not a barrier to receiving needed care. Everything else should be up for grabs, not least of which is how we organize primary care, how we expand on the clinic model, how we tinker with governance. Be bold, experiment, and the system will improve. Secondly, Medicare was founded mainly because there were too many people who do not have access to enough health care. Today we are crossing into a new frontier where all of us may have access to too much health care. The specter of overconsumption and overutilization, the pathologizing of every human condition short of perfection, the costs skyrocket. We do more and more diagnosis. We do more and more poking, prodding, screening, intervening, and yet the health status of the population remains stubbornly unmoved. In fact, we see the prospect of the next generation being the first to experience a decline in health status in the last 200 years. So we have to square this circle a little bit, and we have to realize that healthcare, though a wonderful thing when it is effective, is also sometimes harmful and sometimes merely wasteful. It's incredibly expensive, and the more it consumes of the public purse, the less money we have available to invest in the social determinants of health, of which others have spoken eloquently earlier. Thirdly, I want the supporters of Medicare to be fearless champions of things that aren't particularly popular. And the main thing I want to advocate is a health intelligence system. We of all people should be championing the electronic health record, the mandatory use of electronic prescribing for drugs, and the public and transparent reporting of the system's performance, both good and bad. We should demand that our governments invest more, not less, in health information systems because they are what undergird the best performing health systems in the world. It is not popular to say that maybe we don't need another nurse at the bedside. What we need is a functioning electronic health record. But I assure you, we will never achieve the excellence we all deserve unless we get it. Fourth, and it almost embarrasses me to say this in this room because you're the people who are doing it, but this is a message for the system at large and the citizens. We have to get primary health care right. It is the crucible of health reform, and it is the only pathway to a sustainable and high-quality system. And in particular, the people we are letting down most in this society are not the people who need hip and knee transplants and not the people who need high-end cardiac care, wonderful those are. There are people with 3 or more chronic conditions. They are the frail elderly. They are the people with undiagnosed depression and other mental health problems. This is 60 to 70% of what the current healthcare system is, and frankly, we do a poor job of managing it and looking after these people. They suffer because we haven't succeeded in secondary prevention, preventing the person with type 2 diabetes from having a limb amputated 10 years later. We have not made people well, and we have not realized Tommy's dream of the second phase of Medicare. So you need to be the ambassadors not only for what you do in the clinic movement, but for the whole system. It has to look more like you, not that you should look more like it. Fifth, and this is related, we have to mobilize to rebalance the system a little bit. It is very difficult not to be captivated by the glamour of medicine and the magic of modern surgical interventions, and to be dazzled by the successful new drug that controls the condition. But you see at the back of the room a poster that actually illustrates the battle for the soul of Medicare. In this very city, we had 2 options recently of how to expand the system. One is Station 20 West, one is a new children's hospital. The one at a cost of maybe $8 million in its fuller earlier form, the other at a cost of sure to be $300 million. Believe me, the needs of the system and the second stage of Medicare, the incarnation of that is Station 20 West. And yet the community was unable to turn that situation around. It's not that one should be against something necessarily. But it speaks to what the larger society continues to value disproportionately about Medicare. So we will spend endless and endless amounts of money to help a few children who are already rather well served in our system. With some very difficult circumstances, there will be some families who will be joyous at the prospect of a new children's hospital. But meanwhile, the children on this side of the river, between 20th Street and 11th Street, from Avenue C to Avenue X and T and Z, those are the children that are the next generation, and a new children's hospital will not alter their circumstance. A dozen Station 20 West could transform themselves and their communities, and we need to fight for them. Sixth, we have to recognize that while what Medicare covered at the beginning may have been sensible, hospitals and doctors, the world has moved on. Only 70% of healthcare is publicly financed in Canada, and if you don't need a hospital episode, and you're lucky enough not to, Medicare actually funds a vanishingly small part of what you might need in any given year. We have essentially, by neglect and stealth, privatized things like rehabilitation. We have de-insured valuable services such as optometric care. We have beggared home care at the expense of other and rewarded other services. We are asking frail elderly people to look after other frail elderly people in shockingly large numbers. The system is no longer as just as it once was, and it is far too heavily weighted towards the sharp end of the system. This is not to say that hospitals and specialists don't do wonderful things, but we will not work our way through to a healthier and more just society if we concentrate so heavily on them. So we need to fight to expand the scope of Medicare, as Romano argued, and the way to be able to do that affordably and sustainably is to be prudent in our use of those other ends of the system. We need to have a public conversation about restraint, whether indeed quintupling the amount of diagnostic imaging this year compared to 15 years ago has really done any good. Because if we keep being in thrall to all of this that the system might be able to offer us to reduce a tiny risk to an infinitesimal risk, we will never be able to invest in those social programs. Two more things. First of all, and this is hard for Canadians, but we need to demand more of the system as we have it. It should not be an option in Canada to not prescribe drugs with a computer because there are harms to be caused. It should be impossible to have the degree of polypharmacy that afflicts particularly the elderly in our society and lands a whole lot of people in hospital who needn't be there. One should not have to wait for appointments. Advanced access scheduling works at the clinic. It should be mandatory throughout the province. You should not be able to practice medicine in this province and in this country if you can't offer your patients an appointment within 48 hours. The entire country of England does it. We can do it too, and we must make it a reality. We need to be a bit less polite and deferential when we get some service. If we're going to walk the talk of patient-centered care, we need to reorganize the entire system that respects the time of patients, is organized around our needs, and makes it far easier to navigate for people.
Public health care, something we dare not lose, for it provides services that we choose. It's surely a program needed, the plan that Tommy seeded. We must ensure that it endures, for its coverage we need and choose. Doctors avowed their offices they would close if plan came in. They found that they would oppose. Lord's treatment I hate to mention, as he tried to relieve the tension. But Lloyd stood tall, as we recall, and Medicare came to be. Healthcare clinics with docs for Medicare serve their patients when other docs wouldn't share. Their goal was serving clients with care they could rely on. They proved their worth in Medicare's birth. Now their services people share. 50 years now, Medicare has endured. People agree its strength has been assured. Scientific studies favor a single payer saver, and we'll be switched if we'll be hitched to a private